Good evening, all. We start with our anatomy module, and today's topic is anatomy of the anterior abdominal wall. Along with that, we are going to cover certain topics from the pelvis also. Okay, so we begin with Arcuate Master MRCOG with concept-oriented clarity. So this is the figure which we have learned in our anatomy books. So please concentrate and see. See, this is the costal margin, and this is the subcostal angle, and this is the xiphoid process. And what you see here is the thoracic as well as lumbar vertebrae. Okay, and we know that clinically, when we are examining any patient, we are dividing the abdomen into 9 quadrants, and always there is a one SBA on the quadrants of the abdomen. Okay, so how these quadrants are divided? What are the vertical lines? What are the horizontal planes which divide the quadrant into the 9 planes? So these are very, very basic things, but they are asked in the examination. So concentrate on today's lecture. Okay, so this is the xiphoid process. This is the T10 vertebra. This is the costal margin. Okay, and see, this is the L1 vertebra which is mentioned here, and this is the transpyloric plane. Okay, so this is the transpyloric plane, and this transpyloric plane lies at the level of the lower border of the vertebra L1. Okay, the next plane is a subcostal plane, which is lies at the upper border of the vertebra L3, and third transverse plane is a transtubercular plane, which is lying at the level or which passes through the upper border of the vertebra L5. These three planes are going to be very, very important from the SBA point of view, because they'll ask you that subcostal plane passes through which vertebra. Okay, or at what level it passes posteriorly, and then they will give you various options. Okay, and specifically remember only this L1, that the first transverse we have seen three: transpyloric, subcostal, and transtubercular, out of which the topmost is a transpyloric. The transpyloric passes through the lower border of the L1. Remember L1, L3, and L5. Okay, L1, L3, and L5. And this is transpyloric, subcostal, and transtubercular. Okay, and only L1 passes through the lower border, while these rest of the two will pass through the upper border of the vertebra L3 as well as L5 respectively. Because you will have a confusion, they will give you the L1, but they will give you the lower border of L1, upper border of L1, and then you will confuse if you just remember L1, L3, and L5. Hope I am very clear. Okay, and you are getting this particular concept. So remember, this transpyloric passes through the lower border of the vertebra L1, while subcostal passes through the upper border of the vertebra L3, and transtubercular passes through the upper border of the vertebra L5. So we remember L1, L3, and L5 for transpyloric, subcostal, and transtubercular. Then only the transpyloric will pass through the lower border of L1, while rest of the things like L3 and L5, it is related to the upper border of the. So please do not get confused in the option. This is one of the favorite question. Okay. Then this is the linea semicircularis, that is the lateral border of the rectus abdominis muscle. Then this is the tip of the coccyx. Okay, and these are the landmarks which will divide the abdomen into 9 quadrants. Okay, so we continue with the same concepts. So these are the 9 quadrants. Okay, so here actually they have mentioned here it is a transpyloric plane and the intertubercular plane, which are dividing this into 9 quadrants. But this is also a question: which transverse plane uh, is used for dividing the abdomen? Okay, so at upper level. Okay, this they have used as a transpyloric, but anatomically speaking, this is the subcostal plane which we use to divide the abdomen into various parts, and the other transverse is the transtubercular plane. Okay, in certain books they have mentioned about the transpyloric, but ideally it will be subcostal plane. Okay, why subcostal? Because this transpyloric plane, clinically we will not be able to come to know where does it lie. Okay, because it is related to, as we will go into the subsequent lecture, you will come to know that transpyloric plane is more important for various relations of the various organs which are lying internally. But when we talk about the surface anatomy, generally we talk in terms of the landmarks. Okay, so we will not be able to identify the transpyloric landmark externally, but subcostal landmark definitely will be able to identify. So the subcostal plane we are going to say is a transverse plane in the upper part, which is used. Okay, in lower part it is a intertubercular plane, and the quadrants of the abdomen are, you have right hypochondriac, left hypochondriac, then this is the epigastric, this is the umbilical, this is the right lumbar, and this is also lumbar, this is right lumbar, left iliac, right iliac, and this is the hypogastric. These are the 9 quadrants. Okay, they will also ask you which structure lie in which quadrant. Okay, so umbilical quadrant, which are the structures lying, or which structure does not lie in this particular quadrant? That can also be a question. So we should know these particular very basic things. So as I already mentioned, here is a SBA, that is the transpyloric plane will pass through the lower border of the vertebra L1, while subcostal plane passes through the upper part of the body of the L3 vertebra, and there is another plane passing through the highest point of the iliac crest, which is at the level of the L4. This we have not discussed and not significant from our current discussion point of view. The next transverse plane is an intertubercular plane, upper part of the body of the L5 vertebra. So this subcostal plane and the intertubercular plane, and these two transverse lines and two vertical lines passing from the passing from the mid clavicular line. Okay, so these two mid clavicular lines and these two lines, here we are going to consider the subcostal plane and the intertubercular plane, which are used in dividing the abdomen into 9 quadrants. Okay, now what is the importance of this transpyloric plane? Okay, what are the structures which are present at the transpyloric plane? They may ask you the question, following is not the structure which is present at the level of the transpyloric plane. For this, we should know what are all the structures which lie at the transpyloric plane. Okay, and as we are into more of the basics of the anatomy, that is why I said we may stop in between, maybe after 1 hour, and we'll give a gap so that you can revise today's session. Okay, so we should know the structures which lie at the level of the transpyloric plane. These are pylorus of the stomach, neck of the pancreas, duodenojejunal flexure, fundus of the gallbladder, hilus of the kidney, origin of the superior mesenteric artery, tip of 9 costal cartilage, and termination of the spinal cord. So these are the structures which are present at the transpyloric plane. So they may give you any 4 of these correct, but they may give one wrong, and they may get confused. Say, for example, body of the pancreas. It is the neck of the pancreas which lies at the level of the transpyloric. So you should know correctly. They may give some other part of the stomach also. So at transpyloric plane, we have pylorus of the stomach, neck of the pancreas, duodenojejunal flexure, fundus of the gallbladder, hilus of the kidneys, not the upper pole of the kidney, it is the hilus of the kidney. Okay, and origin of the superior mesenteric artery, tip of 9 costal cartilage, and termination of the spinal cord. So these are the structures which are at the level of the transpyloric plane. Okay, now next plane, transverse plane, is an intertubercular plane. Okay, so this is also called as transtubercular plane. It is an important horizontal and anatomical landmark of the abdomen. So it is an imaginary horizontal plane drawn through the iliac tubercles. Okay, now which are these iliac tubercles? They are approximately 5 centimeter posterior to the anterior superior iliac spine. So if you go 5 centimeter posterior to the anterior superior spine, you will get the iliac tubercle. Okay, so from these two horizontal both sides iliac tubercles, the imaginary line is the transtubercular plane. It usually lies at the level of the L5 vertebra. Which level of the vertebra? Is it upper or lower vertebra? Intertubercular plane? We have discussed. It lies
upper border of L5.
A border.
Yeah, upper border. Okay, don't get confused. Only L1, L1. Which one is that? Transpyloric. Okay, only that will be at the level of the lower border. Okay, this is the figure, while the rest of the thing will be at the lower. Okay, so now what is the key anatomical significance? It is one of the 4 classic planes used to divide the abdomen into 9 regions. The intertubercular plane forms the lower horizontal boundary of the central abdominal region. Structures related at this level are termination of the abdominal aorta. It bifurcates slightly above this plane, generally around L4, but clinically it is correlated. Then formation of the inferior vena cava. Ileocecal junction is usually close to this plane. Beginning of the sigmoid colon and lower poles of the kidney may lie just above this plane. Okay, this is what is the significance of the transtubercular plane. Okay, Now this is the same what we have discussed up till now, the names of the various quadrants. Okay. So this is the subcostal. Here is the image which I showed, because we are discussing about the surface anatomy. Okay, so that is why we are using the subcostal plane and a transtubercular plane or intertubercular as a transverse line, and vertical lines will be the midclavicular line. Okay, and this midclavicular line will join the inguinal ligament, or will cross the inguinal ligament at mid-inguinal point. Okay, so that is what is the significance. The same figure is duplicated here. Okay. Another question they can ask you, which structure lie in which quarter. Okay. So from about onwards, we have right hypochondrium, then we have epigastrium, and then this we have left hypochondrium in the upper part. Okay. So right hypochondrium will be related to the right lobe of the liver, gallbladder, right or hepatic flexure of the colon, right suprarenal gland, and the upper part of the kidney. So these are the structures which are present in the right hypochondrium. Okay, come to the left hypochondrium. We know that there is a spleen, the tail of the pancreas is coming, the stomach, the left suprarenal, and the upper part of the left kidney. Okay, so certain organs are very, very common, and logically we can correlate, but be very, very precise. Do not get confused with the body of the pancreas, the tail of the pancreas, the neck of the pancreas, and all. Okay, the middle part, this epigastrium, will be related to the pyloric part of the stomach, liver, pancreas, duodenum, and abdominal part of aorta. Okay. Now coming to the right lumbar region. So it will be related to the lower part of the right kidney and ascending colon, part of the duodenum, and coils of the jejunum. Okay. So this umbilical region will be related to the abdominal aorta, inferior vena cava, stomach, and greater omentum, then transverse colon. Left lumbar region will be related to lower part of the left kidney and ureter, descending colon, coils of the jejunum. Then the lowest three quadrants, right iliac region will be related to the terminal part of the ileum. There will be cecum and appendix. You have ascending colon and right ureter. Okay, so these are the structures in the right iliac region. The left iliac, you have only the sigmoid colon, the left ureter, while hypogastrium, you have only the urinary bladder. You have the coils of the ileum, but when the bladder is distended, there will be urinary bladder. Okay, and in pregnancy there will be gravid uterus. So these are the structure in the hypogastrium. Okay, so they can ask you one of the SB on this. Now coming to the anterior abdominal wall, important surface landmarks. So what is the extent of the anterior abdominal wall? It is extending from the xiphoid process at the level of the T9 thoracic vertebra to the pubic symphysis, which lies posteriorly at the level of the coccyx. Okay, then superlateral margins of the anterior abdominal wall, you have right and left costal margin, which are formed from the 7th, 8th, 9th, and 10th. Okay, 4th costal, 7th, 8th, 9th, and 10th costal margin. Okay, which reaches its lowest level in the mid-axillary line and formed by the 10th costal cartilage. So lowest one is the 10th costal cartilage. So transverse plane passing through the lowest part of the costal margin is called as subcostal plane. It passes through the third lumbar vertebra that we have already seen. Okay, third lumbar vertebra, which part? Upper part. Okay, that is the subcostal, and it passes through the 10th costal cartilage. Remember this also. Okay, so these are the small things they can ask you. Okay, then subcostal angle, that is the infrasternal angle, lies between the two costal margins, and the xiphoid process lies at the apex of the subcostal angle. That is the level is a T9. Okay, so this is the thoracic level, and this is a costal cartilage. So these are two. This is in the middle. Okay, and this is along the costal margin. Okay, so they are different. So this lies at the level of the T9 vertebra. Then iliac crest, that forms the lower limit of the abdominal wall on sides. Highest point of the iliac crest, that corresponds to the L4 vertebra, which also corresponds to the level of the umbilicus, which also corresponds to the division of the aorta, which also corresponds to the formation of the ilia. Okay, so formation of the IVC. Okay, so these are the things which you should correlate from the anatomy point of view. Okay, then anterior superior iliac spine lies corresponds to the lateral margin of the rectus abdominis upper end so linea similar. What is linea similar? This concept you should understand, because there are three confusing things. One is a linea similaris and second is a linea semicircularis. Okay, so what is linea similaris? It corresponds to the lateral margin of the rectus abdominis. Upper end it reaches to the costal margin at the tip of the ninth costal cartilage and inferiorly to the pubic tubercle. So linea semilunaris is the lateral margin of the rectus abdominis. Okay. Then transpyloric plane we have already seen. Anteriorly it passes through the tip of the ninth costal cartilage and posteriorly through the lower part of the L1 vertebra, roughly a handbreadth below the xiphisternal joint. Okay. Now coming to the importance of umbilicus. Okay. Umbilicus is a site at which the umbilical cord is attached in the fetal life. Position is variable, but in adults, it lies in the anterior median line at the level of the disc between the L3 and L4 vertebra. Okay. So I just mentioned that there are two things. One is a linea semilunaris and second is a linea semicircularis, also called as arcuate line of Douglas. Okay. So linea semilunaris, I have just explained you. It is nothing but the lateral border of the rectus. Okay. So the curved vertical line on each side of the anterior abdominal wall, marking the lateral border of the rectus abdominis. Okay. It is formed by the fusion of the aponeurosis of the external oblique, internal oblique, and transversus abdominis. It is extending from the ninth costal cartilage to the pubic tubercle. Clinical importance, it is a site of Spigelian hernia and landmark for the abdominal incision. Okay, this is what is the linea semilunaris. Now let us come to the linea semicircularis, also called as arcuate line of Douglas. Okay, so it is a horizontal curved line marking the lower limit of the posterior rectus sheath. We know that there is an anterior rectus sheath and the posterior rectus sheath. The posterior rectus sheath is deficient below, somewhere between the umbilicus and the pubic symphysis. Midway between that, the posterior rectus sheath is deficient. Okay, so the lower limit of this posterior rectus sheath is called as linea semicircularis. Okay, so they can ask you the question, the lower, so linea semicircularis, it is a horizontal curved line marking the lower limit of the posterior rectus sheath. Okay, above 1/3 distance between the umbilicus and the pubic symphysis, that is what is the level. Above the line, rectus abdominis has anterior and posterior sheath, and below the line, no posterior rectus sheath is present. Rectus lies directly over the fascia transversalis. So clinical importance is that it is a weaker area. There is a risk of hernia and important during financial and lower abdominal surgeries. Okay. So I hope you have understood the difference between the linea semilunaris and linea semicircularis. Okay. Now the umbilicus we were discussing. So what is the importance of the umbilicus? Anatomical importance as well as clinical importance. Okay. With reference to the lymphatic and venous drainage at the level of the umbilicus, it is watershed. Above the umbilicus, the venous drainage and the lymphatic drainage is in the upward direction, while below the level of the umbilicus, it is directed downwards. Okay. Skin at the level of the umbilicus is supplied by T10 segment of the spinal cord. Then porta cavern anastomosis at the umbilicus, where the tributaries of the portal vein anastomose with the systemic vein. This opens up in the portal hypertension, forming the caput medicine. So this is what is the anatomical significance. Now coming to the clinical importance. So clinically, what you get at the level of the umbilicus, you may get a raspberry tumor or cherry red tumor. It is nothing but the granuloma developing at the level of the umbilicus. Okay. Then there can be remnant of the vitalo-intestinal duct. This may form this tumor. Then persistent of the VID, vitalo-intestinal duct, or the fecal fistula can be there at the umbilicus. Then persistence of the urachus can lead to the urinary fistula. Then there can be examphalus, that is the early fetal life physiological herniation of the intestine in the region of the umbilicus, that will give the examphalus. Okay. There can be ectopia vesicae, that is the failure of the development of the infraumbilical part of the abdominal wall, and there can be hernia due to the weakness of the abdominal wall at the level of the umbilicus. Okay. So omphalocele occurs due to the failure of the reduction of the physiological herniation of the midgut lobe. Herniated loops of small intestine they are covered by the amnion. So that is what is important, that it is covered by the amnion, and it is the herniation of the midgut loop. Okay. Then there can be congenital umbilical hernia. It occurs due to the herniation of the loops of the small intestine through the imperfectly closed umbilicus. The herniated loop is covered by the peritoneum. Okay. Then fecal fistula. It occurs due to persistence and complete patency of the vitalo-intestinal duct through which ileum communicates with the exterior. Then there can be urinary fistula. It occurs due to the patent urachus connecting the umbilicus to the urinary bladder. It may lead to the dribbling of the urine from the umbilicus. Then there can be caput medusae. In case of portal hypertension, the superficial veins radiating from the umbilicus, that is the site of portacaval anastomosis, become dilated and tortuous. It is a referred pain in appendicitis. Referred pain in appendicitis. Referred pain in case of appendicitis is felt at the level of the umbilicus, as both are supplied by the T10 spinal segment. Okay, so the appendix as well as the this umbilical area is supplied by the T10 spinal segment. Okay, now let us see about the layers of the abdominal wall. So layers of the abdominal wall are skin, superficial fascia. This superficial fascia is divided into two. That is the outer campus fascia and the inner membranous scarpa's fascia. Okay. Then there are muscles which are three in number. That is external oblique, internal oblique, transversus abdominis, below which lies the fascia transversalis. Then there is the extraperitoneal tissue and the peritoneum. So these are the 9 layers. From the skin, then you have campus fascia, that is superficial fatty layer. Then you have deep membranous layer of the superficial fascia, that is carpus fascia. Then you have, after that, what you have, the muscles, that is the external oblique muscle, then the internal oblique muscle, then you have transversus abdominis, then comes the fascia transversalis, then comes the extraperitoneal tissue, and then comes the parietal layer of the peritoneum. These are the outside to inside 9 layers of the abdomen. And most important thing is that there is no deep fascia in the anterior abdominal wall. Okay, so it does not have the deep fascia. Okay, superficial fascia below the level of the umbilicus, it is divided into two. Fascia of the camper, that is a superficial fatty layer, and deep membranous layer, that is a scarpus fascia. Fatty layer is continuous with the superficial fascia of the adjoining part of the body, while membranous layer, that is scarpus fascia, is continuous below with the similar membranous layer of the superficial fascia of the perineum, that is the coles fascia. So there is a junction of the coles fascia with the scarpus fascia downwards. Okay. Attachment of the scarpus fascia of the abdomen and the coles fascia of the perineum is such that it prevents the passage of the extravasated urine backwards into the ischiorectal fossa and downwards into the thigh. That is why urine will not get extravasated either into the ischiorectal fossa or downwards into the thigh, and this line of attachment will pass over the Holden's line, the pubic tubercle, the body of the pubis, and the deep fascia on the adductor longus gracilis near their origin, then margin of the pubic arch and the posterior border of perineal membrane. In the median plane, the membranous layer is thickened to form the suspensory ligament of the penis or the clitoris, and this fascia contains variable quantity of fat which tends to accumulate in the lower part of the abdomen after the puberty. So it will contain the cutaneous nerves, cutaneous vessels, and the superficial lymphatics. Okay, so that is what is the superficial fascia. Here you should remember the two layers. That is the fascia of the camper is the superficial fatty layer, and deep layer is called as carpus fascia, that is the deep membranous, and the attachment of these deep membranous layer inferiorly to the coles fascia, and it has got a clinical significance. So whenever there is a extravasation of the urine, it will not permit the urine to have the leak into the either towards the thigh or towards the ischiorectal fossa because of this particular attachment. So this is what is the clinical significance which you should remember. Then coming to the muscles of the anterior abdominal wall. The muscles
Good
of the
evening, sir. Do we?
yeah.
Sir, can I ask a
Yes,
question?
yes, yeah.
Sir, do we have to learn that attachment also? Holden's
Not
line, pubic
necessarily this
tubercle.
Holden's line, the pubic tubercle. They are the questions are not descriptive in nature. they are asking a very important concepts. Okay, so you here I don't think any significant, but your question may be clinically oriented, that there is such and such trauma and then there is a damage to the bladder, and what will prevent the extravasation of the urine. You got it? So they may give you the clinical
Okay, sir. Yes, sir.
scenario expecting you to know the anatomy. You got it? And these particular
Yes, sir.
points are more important, from maybe first year dissection point of view and anatomy point of view. Okay, there is as such nothing much important from here. Okay. Okay, so we'll go ahead. Okay, so muscles of the anterior abdominal wall. Muscles, here also there are few questions SBAs which are very frequently asked, so concentrate on this particular topic. So they are divided into two groups. One is a lateral flat muscle group and another is a central vertical group. Okay, lateral flat muscle, in which there are three muscles, that is external oblique, internal oblique and transversus abdominis. Here we should know the origin, insertion, nerve supply of these muscles. Okay, now, anterior vertical muscles, they are situated bilaterally to the median fiber structure called as linea alba. Okay, so on either side of the linea alba, you will have these vertical muscles. Okay, they are the rectus abdominis and pyramidalis. Okay, pyramidalis is a small muscle, but don't forget there is one SB on pyramidalis also. Okay, and it is absent in 20% of people. That is also one of the SB. How many percentage of patients it is absent? Okay, so what we have seen, total five muscles, three lateral and two central. So we are going to go into the details of this. Okay, we have transversus abdominis, rectus internal oblique, rectus abdominis, external oblique, and pyramidalis. Okay, so these are the this is actually a mnemonic tire pump, but I feel that we should remember straight away. We have external oblique, internal oblique, transversus abdominis, one below the other, lateral, and centrally you have the rectus abdominis and the pyramidalis. Okay. So now let's see about the external oblique. Okay, concentrate, and whatever my presentations are there, no? When you listen to this, you always see the figure. Even when you read, no, you go through the figures, because our visual memory is going to be very, very important here. Okay, see this external oblique, the origin is from the outer surface of the middle of the shaft of lower eight ribs. So it is coming from the above downwards. Okay, so lower eight ribs, it is coming, and it is coming downwards, forwards and medially. Okay, so even the direction is, sometimes they can ask you, how does the fibers of the external oblique go? They go downwards, forwards and medially, and it is inserted into the xiphoid process, linea alba, down to the pubic symphysis, pubic crest, and outer lip of anterior two-thirds of the iliac crest. Okay, so outer lip, this iliac crest has got a outer part, middle part, and the inner part. Okay, so outer part, this external oblique is inserted. Okay, it is inserted here. It is coming from above downwards, and it is getting inserted here between the anterior superior iliac spine and the pubic tubercle. It forms the inguinal ligament. Okay, and the lower part of this external oblique will form the inguinal ligament between the ascis, that is your anterior superior iliac spine, and the pubic tubercle. It will form the inguinal ligament. Okay, so lower eight ribs and getting inserted from the xiphoid process in the midline, coming down to the pubic symphysis and the pubic crest and outer lip of the anterior two-thirds of the iliac crest. Okay, and nerve supply is intercostal nerves 7 to 11 and subcostal nerve. Okay, then coming to the internal oblique. Now this internal oblique is going above downwards. Okay, now it is, the origin is from the thoracolumbar fascia, anterior two-thirds of the intermediate area of the iliac crest, and lateral two-thirds of the inguinal ligament. Okay, so here it is getting originated from the middle part. Okay, as I mentioned, this iliac crest has got three parts: the outer part, middle part, and the inner part. So this outer part is giving insertion to the external oblique. The middle part is giving the origin to the internal oblique. Okay, in the anterior two-thirds of the iliac crest. Okay, and it is also coming from the lateral two-thirds of the inguinal ligament. And this inguinal ligament is formed from nothing but the inferior border of your external oblique itself. Okay, you got it. and out of that lateral 2/3 of the inguinal ligament will also give origin to the this internal oblique. Okay, and it is inserted over the lower 3 to 4 ribs, xiphoid process, linea alba, and pubic crest. Okay, so here the nerve supply is intercostal nerve 7 to 11, subcostal, iliohypogastric, and ilioinguinal nerves. Okay, this muscle is uh, going down below, so you have additional iliohypogastric and ilioinguinal nerves. Here only the subcostal and intercostal were there. So here you have intercostal, subcostal plus iliohypogastric and ilioinguinal nerve. Okay. Then transversus abdominis. Transversus abdominis origin is from the lower 6 ribs, thoracolumbar fascia, and anterior 2/3 of the inner lip of the iliac crest. Okay, so here comes the inner lip of the iliac crest. Okay, this is the origin of the transversus abdominis, and lateral 1/3 of the inguinal ligament. It is getting again inserted into the xiphoid process, linea alba, pubic crest, and pecten pubis. And here same nerve supply like the internal oblique, that is intercostal nerve 7 to 11, subcostal and iliohypogastric and ilioinguinal. Okay, so these two have got the same nerve supply, internal oblique and transversus abdominis, intercostal nerves 7 to 11, subcostal, iliohypogastric and ilioinguinal, and it has got this one only intercostal nerves 7 to 11 and subcostal. Okay, here only what is getting added is iliohypogastric and ilioinguinal. Okay, so three are over. Then last one is the rectus abdominis. This we will go into detail further, but it has got two heads. Lateral heads. It has got two heads, huh? And one of the peculiarity of this muscle is, what is peculiarity of this particular muscle about origin insertion? Can anyone tell me? Normally, where is the origin and where is the insertion? Normally, proximally the muscle gets originated and it travels distally. The rectus abdominis is getting originated from here, okay, and it goes up, okay, vertically up and getting inserted here. So lateral head is coming from the pubic crest, okay, and the medial head is coming from the anterior pubic ligament. Okay, so it has got two heads. The lateral head is from the pubic crest and medial head is from the anterior pubic ligament, and it is getting inserted over the xiphoid process and costal cartilages 5 to 7, and same nerve supply as the your external oblique, that is intercostal nerve 7 and 7 to 11 and subcostal nerve. Okay, so these two, rectus abdominis and external oblique, same nerve supply. Intercostal nerve 7 to 11 and subcostal. So rectus abdominis, central part, and the external oblique, same nerve supply, while internal oblique and transversus abdominis, same nerve supply. Okay, intercostal 7 to 11, subcostal, along with the iliohypogastric and ilioinguinal. Okay, so that is what is the. Now, what are the actions of the anterior abdominal wall muscle? It will support and protect the abdominal viscera, help in force expiration that occurs during coughing, sneezing, vomiting, increase in intra-abdominal pressure, and thereby help in defecation, micturition, and parturition. Rotate the trunk to the opposite side. So external oblique of one side and internal oblique of the other side will cause rotation of the trunk to the opposite. So you can rotate your trunk to opposite side. At that time, what is happening? The external oblique of the same side and the internal oblique of the opposite side is working. When you flex the trunk laterally, okay, now you are not rotating, you are flexing the trunk laterally. That means same side external oblique and internal oblique are in action. Okay, now if when you flex the trunk anteriorly, it is the rectus abdominis muscle which is coming in picture. So these they can ask these things. When there is a lateral rotation of the trunk, which muscle is acting? It is the same side external oblique and the opposite side internal oblique. When you flex the trunk laterally, it is same side external oblique and internal oblique are acting. When you flex the trunk anteriorly, it is the rectus abdominis. Okay. Now there are two things. One is a linea alba and another is a linea semicircularis. Okay, both are vertical lines, but one is in the center and one is at the lateral border of the rectus abdominis muscle. Okay, linea alba is an avascular fibrotendinous raphe formed by the interlacing fibers of the aponeurosis of the three lateral muscles of the anterior abdominal wall. That is the external oblique, internal oblique, and transversus abdominis. So it is a avascular fibrotendinous raphe formed by the interlacing fibers of the aponeurosis of the three lateral muscles. It extends from the xiphoid process to the pubic symphysis. Then you have a linea semicircularis, a curved fibrous line at the lateral margin of the rectus sheath that extends from the tip of the ninth costal cartilage to the pubic tubercle. Okay, so lateral margin of the rectus sheath. Okay, so coming to the now, we'll go into the details of this rectus abdominis. Okay, so this is the rectus abdominis muscle. Okay, and this lateral is the linea semilunaris. Okay, here is going to the linea alba, and linea semicircularis will be somewhere here posteriorly. Okay, so these few things which should not cause any confusion to you. So rectus abdominis, we have seen it has got two heads. Okay, medial head and the lateral head, a pair of long straight muscles which run vertically on either side of the anterior abdominal wall. They are separated by the linea alba. The term rectus abdominis means straight abdominal in Latin, indicating that the muscle fibers run in a straight vertical line through the abdominal region of the body. Each muscle consists of string of four fleshy muscular bodies connected by three narrow bands of tendons known as intertendinous intersections. Okay, so these are the tendinous intersections. Okay, the shape of these segments is often visible through the superficial fascia and the skin in those with low body fat, resulting in six-pack shape. So these, because of this intertendinous intersection, we get this six-pack shape in the people who have the less abdominal fat. Okay, now the another important muscle is a pyramidalis. Okay, so this pyramidalis muscle is a small triangular muscle lying anterior to the rectus sheath, anterior to the rectus abdominis muscle, that can be absent in approximately 20% of the population. It is contained in the rectus sheath and originates from the bony pelvis, where it is attached to the pubic symphysis and pubic crest through the tendinous fibers. The fiber will run superiorly and medially, so they will run superiorly and medially to insert into the linea alba, tensing it during the muscular contractions. Okay, so this is a very small muscle. Okay, now what are the arteries of the anterior abdominal wall? The and arteries are the mainly it is getting supplied from the internal thoracic artery and external iliac, the femoral arteries, and the posterior intercostal arteries. Okay, so this internal thoracic artery coming from here. Okay, so this internal thoracic artery will give the superior epigastric. Then you have the lateral cutaneous branches of the posterior intercostal arteries. Then superficial epigastric is a branch of femoral artery. Okay, this actually coming somewhere here. Superficial epigastric is coming from the femoral artery. The external iliac will give inferior epigastric and the deep circumflex iliac. So these are the branches which will supply the anterior abdominal wall. They will not ask such a minute details. Okay, this is just for your understanding purpose I have explained, but otherwise I don't think here they will ask you any single based answer question. Venous drainage, we have seen the umbilicus is a watershed. Okay, what happens in the portal obstruction? You get here the caput medusae. Then when there is a blockage of the superior vena cava, so if the SVC is blocked, so then the venous drainage will be downwards. If the IVC is blocked, the in case of inferior vena cava obstruction, the arrows will indicate the direction of the blood flow. So there will be venous drainage in the upward direction. Okay. Now the cutaneous nerves. Skin of the anterior abdominal wall is supplied by the lower six thoracic and the first lumbar nerve. Okay, so lower six thoracic, T7 to T12. These are the six thoracic nerves, and another one is a ilioinguinal nerve. Okay, so these seven nerves will supply the skin of the anterior abdominal wall. Okay, so anterior cutaneous nerves, which are seven in number, are derived from the lower five intercostal nerves, subcostal nerve, and ilioepigastric. They pierce the anterior wall of the rectus sheath close to median plane and divide into medial and lateral branches and supply the skin of the front of the abdomen. Here you can remember this. So near the xiphoid process, you have the T7. At the level of the umbilicus, you have the T10. The iliohypogastric is situated an inch above the superficial inguinal ring. Okay, so this is the 1 inch above the superficial inguinal ring. You have this iliohypogastric and others at proportionate distance between them. Okay. Now the lymphatics. Again, lymphatics from the anterior abdominal wall above the level of the umbilicus, they will drain into the axillary group of lymph nodes. Okay, so this umbilicus acts as a watershed line. Above this level, they will go to the axillary group of lymph nodes, and below this line, they will go to the superficial inguinal group of lymph nodes. Okay. And another thing which they can ask you about the this is the transverse section through the anterior abdominal wall. Okay. So what you can see here is the inner. This one is a transversus abdominis. This is the external oblique. This outer one is the external oblique, below which is the internal oblique. Okay. And here these are the muscle vessels and the nerves. This yellow color is the nerve. Okay. This nerve is piercing this internal oblique, external oblique, and then it is getting divided. Okay. And here there is a vessel. Okay. From the aorta, these are the vessels which are passing like this. Okay. So the neurovascular bundle of the anterior abdominal wall is lying between this transversus abdominis and this internal oblique. Okay. In between these two muscle lies your neurovascular bundle. So they can ask you the neurovascular bundle of the anterior abdominal wall lies in between which layer, whether it is external oblique and internal oblique, whether it is internal oblique and transversus abdominis, whether it is transversus abdominis and fascia transversalis, or they can give any other option also. So you remember there are three muscles: external oblique, internal oblique, and the transversus abdominis. Between the internal oblique and between this transversus abdominis, this is the neurovascular plane. Okay, you see this nerve yellow is passing like this. Okay, and this is the vessel which is passing between these two. Okay, so neurovascular plane lies between the this transversus abdominis and the internal oblique. Okay. Now coming to the rectus sheath, this is very, very important. Here there will be question. Definitely one SBA will be there. Okay, formation of the rectus sheath. Okay. Now rectus sheath is an aponeurotic envelope for the rectus abdominis and pyramidalis muscle. It is situated on either side of the linea alba, strengthens the anterior abdominal wall and prevents the bowstringing of the rectus abdominis muscle. Okay, it has got anterior and posterior walls and medial and lateral margins. Okay. Now, how it is formed, that is going to be very, very important. I have already posted this particular video in the group. I hope you have listened to it. What is the difference in various parts in the formation of this rectus sheath? Now let us see the anterior wall of the rectus sheath. See, this rectus sheath has got anterior wall and the posterior wall. Okay, so anterior wall is complete, but it differs in the thickness at different level. Okay, now in the region above the costal margin, okay, it is thin and formed by the aponeursis of only external oblique. Okay, in the region from the costal margin to the midway between the umbilicus and the pubic symphysis, it is thicker and is formed by the anterior lamella of the aponeursis of the internal oblique with the aponeursis of the external oblique. Okay, so IO internal anterior lamina and EO, that is external oblique, that will form the in the region between the costal margin and midway between the umbilicus and the pubic symphysis. And in the region between the midpoint of the umbilicus and pubic symphysis to the pubic symphysis, it is the thickest and is formed by the fusion of all three flat muscles of the abdomen, that is external oblique, internal oblique, and transversus abdominis. Okay, so anterior wall of the rectus sheath is adherent to the anterior surface of the rectus muscle along three tendinous intersections. This we have already seen. Okay, so this is what is the difference. Okay, there is a difference between the anterior wall and the posterior wall. Anterior wall is complete and it covers the muscle from end to end, but the composition is variable. Okay, so the composition is variable and it is firmly adherent to the tendinous intersections of the rectus muscle. While posterior wall is incomplete, it is deficient above the costal margin and below the arcuate line. The composition is uniform and it is free from the muscle. So that is what is the difference between the anterior wall and the posterior wall of the rectus sheath. So they may give some, ask any peculiarity of the this particular rectus sheath for the anterior wall, and most commonly is they will ask you SBA with respect to the formation of the rectus sheath either below the level of the arcuate line, or they may ask between the costal margin and the arcuate line, or above the costal margin. Okay, so this is above the costal margin. Above the costal margin, here you can remember just one thing. In anterior wall, the formation is variable. Okay, so above the costal margin, thin, then becomes thick, and then become thickest. Okay, thickest is down below. Okay, between the midpoint of the umbilicus to the pubic symphysis, it is thickest, where all three aponeurosis will go anteriorly. Okay, while in the middle region, what happens? This middle internal oblique gets split into two, anterior lamina and posterior. This transversus sorry, internal oblique will split into two, anterior lamella and the posterior lamina. Okay, so this anterior lamella will join with the external oblique, while the posterior lamella will join with the transversus abdominis. Okay, and that will form the posterior wall of the rectus sheath in the middle part, while in the upper part the posterior rectus sheath is absent, and here what you get is a external oblique only. Okay, and where does these two go? The transversus abdominis and the internal oblique, they do not come centrally, they are going laterally and getting inserted in the costal margin. So that is why in the central part it is deficient. Okay, so now coming to the posterior wall. So in the region of the above the costal margin, we are talking about the posterior wall. Now, posterior wall above the costal margin, in this region, the posterior wall is deficient, and the rectus abdominis rests directly on the fifth, sixth, seventh costal cartilages. The posterior wall of the rectus sheath is deficient here because the transversus abdominis muscle passes internal to the costal cartilages, and internal oblique muscle is attached to the costal margin. Okay, that is why it is deficient in this region. Okay. Then in the region between the costal margin to the midway between the umbilicus and pubic symphysis, it is formed by the posterior lamina of the internal oblique with the aponeurosis of the transversus abdominis. Okay. A crescentic border called the arcuate line marks the inferior limit of the posterior wall of the rectus sheath. This is the line which is called as linea semicircularis. Okay, it is usually midway between the umbilicus and the pubic crest. Okay, then in this region between the midpoint of the umbilicus and pubic symphysis to the pubic symphysis, it is formed by the fascia transversalis. Inferior to the arcuate line, the appendices of the all three flat muscles pass anterior to the rectus muscle to form the anterior layer of the rectus sheath. Okay, so let us see this figure again. What happens? All three lamella, all three muscles, that is external oblique, internal oblique, transverse abdomen, will go anteriorly below the arcuate line, and that is why this muscle will rest directly on the fascia transversalis. Okay, and here it is thin above the costal margin, while it is deficient posteriorly. So above the costal margin, the posterior wall is deficient. Below the costal margin, it is deficient. It is directly lying on the fascia transversalis. Only in the middle, this transversus abdominis gets split into two. Okay, so they can ask you this formation in one of the SBA. Okay, so this formation of the rectus sheath, this is the same thing is explained here. Above the costal margin, anterior wall is made up of only external oblique aponeurosis. Posterior wall is deficient and directly rests on the costal cartilage. Between the costal margin and arcuate line, anterior wall is external oblique and anterior lamina of the internal oblique. Posterior wall is formed by the posterior lamina of the internal oblique and aponeurosis of the transversus abdominis muscle. And midway between the umbilicus and pubic symphysis, the posterior wall ends in the arcuate line. Okay, so this posterior wall, it ends in the arcuate line. Okay, below the arcuate line you have the anterior wall, aponeurosis of all three flat muscles of the anterior abdominal muscles. Okay, but external oblique remains separate. Okay, then posterior wall is deficient and rectus muscle rests directly on the fascia transversalis. Okay, in the region of the above the costal margin. Above the costal margin, this is only the external oblique aponeurosis. Okay, and posteriorly you have fifth, sixth, and seventh. Fifth, sixth, and seventh costal cartilage. So it is resting. This muscle is directly resting on these particular costal cartilages, and the posterior wall is deficient. Okay. Now you see from the costal margin, midway between the umbilicus and the pubic symphysis. Okay, from the costal margin. Now what is happening here? This Internal oblique is splitting into two, anterior lamina and the posterior lamina. So you have both layers. So anteriorly you have external oblique and anterior lamina. Posteriorly you have the posterior lamina and the transversus abdominis. Okay, that is forming the posterior rectus sheath here. Okay. Then when you go here, all three are coming anteriorly. Okay. Appendices of the external oblique, appendices of the internal oblique, and appendices of the transversus abdominis. All three are coming anteriorly. Posteriorly, there is only the fascia transversalis. Okay. So what are the contents of the rectus sheath? You have the muscles like rectus abdominis, pirimedalis, then blood vessels, superior epigastric, inferior epigastric, nerves, terminal parts of lower pie intercostal and subcostal nerves. Okay. So same thing is, it is deficient posteriorly above the level of the costal margin. It is deficient midway between the umbilicus and the pubic symphysis. Okay. So this is what is the